So there are a number of products that better support maternal and reproductive health and support climate change. And there's a lot to learn about how those products go from being an idea to an integral part of a health system. And I want to tell you about one product in particular. And Nonso, who is on the panel, will do justice to tell you a bit more about how they've worked to introduce this product in Nigeria. And this product is heat-stable carbetocin that is designed to withstand high temperatures and to save women's lives in its journey from research to access. So back in 2018, the initiative that I work for, MSD for Mothers, was in its formative stages. They had reached out to global stakeholders, to shape focus. The guiding principle at the time, and it still is addressing preventable maternal mortality in countries with high maternal deaths like Nigeria. We knew that the leading cause for maternal mortality was postpartum hemorrhage, which is the severe bleeding after childbirth. And we heard from the global community, including the UN Commission on Life-Saving Commodities and the WHO, that there was an issue around the quality of medicines used to prevent postpartum hemorrhage. These medicines are called uterotonics. Now, this is the research part of the story. The issue around quality was that the gold standard uterotonic was less effective when it's exposed to high temperatures, a climate change issue. We needed to find a more heat-resilient product so that women would have a reliable, high-quality medicine to prevent postpartum hemorrhage. So MSD was uniquely positioned to address this issue as an innovator in the pharmaceutical space. So we took the input around quality from the community back to our R&D teams and explored if we could make the gold standard uterotonic more heat stable. When we realized that any chance of success would require a long R&D journey, we abandoned this approach. Despite the setback, we remained committed to pursuing development of a quality heat-resilient uterotonic. So we looked for external partners, and somebody on the panel spoke about the importance of partnerships and collaboration. We engaged another pharma company, Ferrin Pharmaceuticals, who had recently re-engineered its uterotonic carbetocin into a heat-stable formulation. The company was interested, but it lacked the reach into countries with the greatest burden. At this point, we saw the solution, which was to expand heat-stable carbetocin's access into countries where medicines were routinely exposed to high temperatures and where maternal mortality was high. But we needed a pathway to globalities updated. We shifted to country implementation with the support of local partners. Some of you may know that the path from global policy to bedside access, it involves many steps, and Nonso will probably tell you a bit about that journey. So MSD for Mothers knew that we had to work closely with governments, healthcare providers, implementers, and Ferrin to reach mothers with global players and with global players to reach scale. This parallel approach is particularly important in the context of the changing status quo, a challenge which many needed climate resilient products are likely to face. On the implementation side, we worked with to be part of the solution, and I'm telling you this story to let you know that this is an example of collaboration. It's an example of a situation where heat, a climate issue, is affecting the health outcomes of women, and how coming together and working together over time consistently can deliver outcomes. So I'll just leave you with that. I think I've said more than enough about what we've done, and I'm going to hand over the conversation now to Onyedikachi. I want you to listen to what the panelists have to say. Please come with questions. We're all here to learn. I've learned a lot already, and I'm looking forward to learning even more from the distinguished experts that Nigeria Health Watch has curated for today's conversation. Thank you.
Thank you very much. Please, a round of applause again for Iyaduni as she takes her seat. Yes, it's a comfortable place to learn. because this event put together is always an eye-opener on a vast range, a wide range of topics. Without taking much of your time, I will now introduce and welcome to the stage our distinguished panelists. First on my list, I have, he is the Professor of Obstetrics and Gynecology at the Faculty. Let's welcome Professor Christopher Aimarco. Please, a round of applause. Also joining us virtually due to the conflicting events, there's the ministerial retreat going on currently at Bauchi, and he was unavoidably absent. We have Dr. Samuel Oyeniyi. He is the Director for Safe Motherhood Department, Federal Ministry of Health. Please, a warm applause for Dr. Samuel Oyeniyi. We have in our midst the Project Director for Smiles for Mothers. Smiles for Mothers is a project implemented by Solina Center for International Development and Research, CIDA, Nigeria. Please welcome Dr. Chukwunonso Wokorie. And we also have the Associate Manager, MDoc Healthcare. MDoc is focused in providing digital health and data solutions for improving maternal health. Please welcome Chiagozie Abiakam to the podium. And lastly, I have the Officer for Sustainability and ESG Unit, Nigeria's Sovereign Investment Authority, NSIA, Faithfulness Onyeloye. Please, Faithfulness, join us on the stage. Thank you. Okay, so I would
like drought, which eventually leads to things like famine. You have stagnant waters, you have people displacement, and the trauma of even trying to run to safety after these natural disasters have happened causes a lot of stress, anxiety, depression on the women, predisposing them to health conditions like hypertension, high blood pressure, preeclampsia, and the rest. And so that's why we believe in this panel, in our conversation, that women, particularly pregnant women, are more vulnerable to the effects, of climate change. Looking at the IDP camps, when people displacement happen, you see them all, we push them, or the government pushes them to IDP camps, which are supposed to be safe zones. But by the time you get to see it, overcrowding happens, poor sanitary conditions, right? And then, even the quality of water, the quality of the food. And we know that when a woman is pregnant, she needs much more nutritional benefits than an average person, right? And so these are the factors that make pregnant women, newborns, more susceptible to the effects of climate change.
Thank you very much. Thank you. So maternal health indices are already crying for urgent attention, and now climate change is putting more pressure on these health indices already. And we know that maternal deaths from preventable causes, like Chiagozie is going to tell us later on in this panel, are caused by preeclampsia, other complications, and the leading cause being a postpartum hemorrhage. So I would still come back to you so that we can further discuss on the existing data research that we need to better understand the link between this climate and maternal health outcomes. But I'll move over to Prof. What are those most pressing maternal health risks? You are in the field of taking care of women, especially when they are pregnant. So what are the most pertinent and pressing maternal health risks that are related to climate change? And being the second vice president of SOGON, how is the Nigerian health system responding and adapting to these risks?
Thank you very much for your questions. Good afternoon, everybody. I always feel funny when I have to talk about maternal health and the risks we have in Nigeria. If you look at the maternal mortality rate, it keeps rising despite what we do. Even the attention that government does give keeps rising. Nigerian government is very good when it comes to writing health policies or protocols, but do we practice them? When you look at pregnancy, like she said, is not just the mother. It involves the baby, it involves the family. And we learned in school that pregnancy, the baby is like a parasite. The baby must take from you. Now, what happens is that there's so many complications that are associated with climate change. When we're talking about climate change, like she said, we're talking about extreme weathers. We're lucky enough we don't have flooding too much, except the recent ones. And I heard yesterday that somewhere in Edo State, they've told the women to move. So, and then we don't have cyclones, but we have stress. Stress now is a very big problem. Stress is one of the risk factors things that climate change has put on the pregnant woman. And with stress comes depression, comes anxiety, and other things that do follow. And with that, you now have a lot of complications that do happen with pregnancy. Pregnancy-induced hypertension, quote me now, is the greatest killer right now. We used to think before it was seasonal, during the rainy season. Right now, I work in a tertiary hospital. There is no week that you don't see women that have high blood pressure. Even those that you book and those that are not booked. So we're seeing quite a lot, and that's because of the stress. Stress and other factors that these women go through. On the woman itself, you see a lot of other complications. Things like this, meeting with other health people and the press and everything, will help us, because you need to do a lot of advocacy. We're doing a lot of training a lot of our health personnel in terms of how you take care of many of these complications. But the sad thing with Nigeria, Sakpa syndrome. Sakpa syndrome. They are medical students. You train them, they become doctors. In our days, we wanted to buy cars, televisions, and everything. Nowadays, these young guys want to have money to do exams and get out. They're not even interested in getting married or anything. So you train, and where do they go to? I examine in so many medical schools in Nigeria, not just doctors, but other health personnel. People don't want to stay around. So the government has to do something to encourage people to hang around to help. We need to train. Train means training a lot of people. Then infrastructure. I mean, look at what happened to the flood in Maiduguri. Destroyed one of the best cancer centers in Nigeria. Completely. You saw the CMD. Was flooded to his waist. People went there to inspect that facility a few weeks before that. They said the place was okay. And what happened? The rains came and that was it. So those are a few things I want to say. In very good countries, but no, don't quote me because I know the press is here. In advanced countries, they have cooling centers. They are dehydrated. They don't eat before they come. And those are the challenges that we do have. Thank you very much.
Thank you very much, Professor Aimaku, for expounding on those very pressing maternal health issues, heat waves leading to stress, and even infertility. And also that also points us back to the earlier discussions we've had at plenary. When we talk about flood displacing women, we now see the need for even climate smart audio so he can hear me.
Are you hearing me now?
I can hear you. I've always heard you. Can you hear me?
Yes, I can.
Can you hear me now?
Yes.
Oh, great. Okay. So we've been discussing on the reason why women are the most vulnerable to climate change issues, why they are disproportionately affected. And we've gone on to further discuss on the most pressing maternal health risks that are related to climate change as it affects women. So we would want to know from you, what are the key policies or initiatives that are being put in place or have been designed or implemented to mitigate the impact of climate change on mothers? And if you can also take it further, tell us how these can be scaled, not just at the national, but also at the subnational level.
Yeah. Uh, Thank you, the moderator. I want to appreciate everyone that is there listening to us. And thank you for this topic. It's very timely based on what we are experiencing. For government, we have put in place a lot of interventions and policy. I also want to answer the question that Professor Imaku said. Many a time we put up these policies, but they are not being implemented. And one of the policies that we've put up in the recent time is the Safe Model Strategy. The Safe Model Strategy is a strategy that will help us to implement all the interventions which we don't have before now, since the creation of the Department of Family Health, or when we had the 1989 meeting in Cairo. Nigeria does not have a strategy for safe motherhood. And we have been able to do that in the recent time. We now have a strategy on the direction to go, including the effect of climate change in that strategy. And we've been able to look at the maternal health complication. By the way, I need to let us know that maternal health, yes, is not the only one we look at. We work integrated, like somebody said. We look at RAMCA in a continuum of care, because even before you are pregnant, your status will tell us what you will do in the next 9 months. And when you do that and you deliver, the newborn comes in. So it's a continuum of care, and that one will go to grow to child as a child. And what happens to a child in childhood will also affect majorly what you put up as an adolescent. And what you do in that also, by the time you become an elderly, which very our elders, and there are a lot of intervention government has put in place to do that. So we are looking at this effect along the continuum of care.
Okay, network challenge we have there. Sure, once his connection is back, we'll continue the conversation and he will continue his line of thoughts. So while we wait for him to reestablish connection, I would come to Dr. Nonso. It's interesting to know that.
And to the Nigeria Health Watch team for inviting me. I think before I answer the question, I'll provide some context. So Smiles for Mothers is a consortium made up of Solina, Center for International Development and Research, and Clinton Health Access Initiative, CHI. As you might have gathered from Yaduni's preamble, we kind of continued the story that MSD for Mothers, Ferring Pharmaceuticals, and WHO started in trying to create a public access price heat stable capital, because frankly, heat stable capital had actually existed even in Nigeria before we came on board. But the brand that was available was quite expensive. It's called Fabal. And what we did was really then to facilitate that introduction of the public access price one. And we used a very simple framework, which I think also addresses some of the points Professor Imaku raised about that gap between policy and implementation, which was really built on 3 pillars. First is necessary policy updates. And the second is the commodity itself, making sure it's available. And of course, the third is the health workers, make sure they have the capacity. So for policy updates, we work very closely with Dr. Yeni and other folks at the Federal Ministry of Health to update the necessary policies, the essential medicine list, the life-saving skills manual, and a few other things. We also worked to create that linkage between Ferring's distributor in Nigeria, IDA Foundation, and the states we were working with at the time, which were Kano, Lagos, and Niger, so that those states could then procure the commodities. And of course, we facilitated the training of healthcare workers on EMONC, because for us, we're also looking at it as a system-wide thing, not just focused on PPH. Initially, it was those 3 states with support from MSD for mothers. Recently, we've been able to get some more states with additional funding from BMGF. This is also part of what we gained from the work we did by just also socializing what we're doing to other funders. So we now have other funders putting in money for the introduction of new and lesser used medicines like heat-stable carbetocin. It's important to note that the value that heat-stable carbetocin brings is that it doesn't need refrigeration, unlike oxytocin, which is the commonly used uterotonic for prevention and treatment. The other things we did was to then document our experience as a project. And working with the Federal Ministry of Health, we released what we call a playbook, which essentially any entity, any state, any donor could use to replicate what we have done. Some of the other things we did to make sure heat-stable carbetocin was used on a wider scale was also still leveraging some of the policy updates that were happening at the time. The safe model strategy that Dr. Yeni mentioned is one example. Other examples include the recently done maternal health commodities forecast. So essentially, we're making sure heat-stable carbetocin featured in all these updates, in all these ongoing conversations. We also worked with the Federal Ministry of Health to prioritize states with the biggest PPH burden. As you might imagine, no story is complete without the challenges. The challenges have, of course, included funding, the biggest one, especially in a tightening fiscal space, bearing in mind the fact that there is enough analysis also that shows that heat-stable carbetocin is quite cost-effective, but it's cost-effective in comparison to other uterotonics, especially when you factor in the quality of those uterotonics, which are, in the case of oxytocin and to some extent, bisoprostol, affected by climate conditions. So I think those are important things to note, the finance bit, but I think the lesson we've also learned is there's so much opportunity, to address some of these challenges. The finance, typically people would say government should provide more finance, but the simple solution, for example, is just even pooling procurement. So instead of procuring as states could actually come together, pool their procurements, and that in itself would drive down the cost of heat-stable carbetocin and, frankly, other maternal health commodities. I would say another big challenge we still have is the awareness. So despite the work we've done, I was even having an interesting conversation with Prof last night, where from conversations with other clinicians in states where we haven't worked, people are still not very aware of heat-stable carbetocin, or even those who are aware of heat-stable carbetocin still think it's at that very high price. But I think the good news is that with the additional funding from other donors, the sensitization that we're doing in this kind of events and other events, gradually people would be aware and would take up the use of heat-stable carbetocin. Thank you.
Thank you very much, Dr. Nonso. Please, a round of applause as we, take that in. And I've been told to perform, I would call it magic. When we started this session, I thought we would have it till 2:40, but we have less than 7 minutes to wrap up the thoughts from all our panelists and also engage with your questions. So we are going to be really quick. But because we want to hear from MDoc, yesterday I told you I find it fascinating the innovations you bring into the maternal health space, and I really see digital health as the future of health. So tell us, how is MDoc leveraging the digital health solutions that you have to prevent and increase access to women for them to access care in the face of climate change, the face of flood, drought, and other climate-related experience? Thank you.
Thank you very much.
In 2 minutes.
Thank you very much, Kachi, and thank you, Nigerian Health Watch and MSD for Mothers for putting this breakout session together. Like my colleagues have mentioned, bad roads, flooding. One of the speakers at the plenary talked about the mysterious disease that's actually killing children. They are drinking water and they're dying mysteriously, not knowing what is killing them. So at MDoc, we're leveraging AI technology to improve access to care for women of reproductive age, at the same time empowering them, building their digital and health literacy. We're intentional about them being able to make informed decisions about themselves. During the course of our work, we have conducted studies and found out that 50% of the women that we serve are obese. 40 to 60% have something called nutritional induced anemia, right? Only 26% eat the right proportion of fruits and vegetables per day, right? So we introduced a product called Garden in a Box. It's a very small product, but it's powerful, right? These are vegetable seeds that have been laced with fertilizers. They are very easy to use. You can feed a family of 4 for 1 month, right? And we're giving these seeds to women, empowering them to, or giving them the agency to actually create a garden, right? So it's even them just knowing that, oh, I have pepper seeds in the house, I have garden egg seeds, and I can put it in the soil, and it will grow, and this will feed my family. And of course, it's green. Green is reducing carbon dioxide in the air. Another way, and I would say it's like preparing the health system for being adaptive and responsive to disruptions that are caused by climate change. I'll very quickly give a typical example. I spoke about that yesterday, where a woman said that she came into the facility to have her baby, right? Labor and delivery. She was in labor and she came into the facility to have a baby. And then while she was leaving, she left with malaria, right? She had fallen sick. And this is because the sanitation in the facilities were poor. There was stagnant water, there was flooding, right? And then she went on our platform, navihealth.ai, and left a review about that, very detailed review about that. And this caught the attention of the facilities, it caught the attention of health system leaders. And then they came in and they cleared the stagnant water, they cleaned up the bushes, they, integrated mosquito nets into their the labor and delivery package, so that every woman that comes into the facility has mosquito nets, to cover her and prevent her from getting malaria. You come into the hospital to get saved. You don't expect to get sick while you're leaving, right? These are just ways that we're preparing or helping the health systems to be adaptive and responsive to, the changes that climate change is bringing. Thank you, and I'll pause here.
Thank you. Do we have Dr. Sam Oyeniyi back so we can just share a final thought with him? Okay, I saw his video earlier. So we would like to take 2 questions from the audience. I have 2 hands already up, and I have 3 more, but I'm going to take 1 man and 1 lady, and that will be the first 2 hands that I saw. So please just introduce yourself, and in 30 seconds, let's have your question so that the panelists can have more time to respond. They're just seated on the 2nd row. Yes, please. Ladies first.
Good afternoon, everyone. My name is Sandra, and I'm a midwife. Okay, my question goes to the MDoc rep. Okay, you spoke about the AI, the tech thing and all that. And we know that, and the scenario you played out about the stagnant water and all. Okay, now, the AI thing, we know is the linear, the educated people that can access that and use that, should I call it platform? And now the learned people, the educated one, people in the urban settings, they would not really experience or have this live around the stagnant area, a water area, like they'll keep the environment clean. Now my question is, what method have you put in place for the people in the rural area to access healthcare remotely? That's my question.
Thank you. The second question.
Thank you very much. My name is David Agunolofi. I work with Options. My question goes to Prof. Christopher while drinking water. So, given these direct and indirect impacts on climate change, of climate change on health infrastructure, so how can we ensure that maternal health services remains accessible and resilient, particularly in rural and this hard-to-reach area? Thank you.
Okay, so Dr. Chiagozi.
Thank you so much for your question. In order to support women in the rural areas and low-income communities, what we've done is that we've been very intentional around building digital literacy, and we used an approach that we call phygital. So it's physical and digital, right? We know that you cannot just go pure virtual. So we've created community-based nudge hubs, and we have roving community ambassadors. We have outreaches where we actually go and meet the women where they are, right? And then build their digital literacy, help them walk through how to use, the digital platforms, while also creating the AI chatbot, for instance. We were very intentional around co-designing with the women in mind. So we had iterative user testings where it's the women telling us this is how they want the chatbot to respond to them. This is what they want the chatbot to do, right? And to that end, we now ensure that our chatbot, for instance, responds in pidgin, right? So they can ask, their questions in pidgin and get responded to. We're also integrating voice to text so that women that are not literate enough to type, their engagements with the chatbot are able to speak to it and it will respond to them in a way that they can understand. That's just, in a nutshell.
All right, thank you. I hope that was able to answer your questions. Yes. Thank you. And the second question was directed to... Okay, Prof.
Hello. Okay.
All right.
I will answer your question. I think Nonso also wants to chip in to what I want to say. Talking about infrastructure, we find out that one problem we have is government facilities are always politically located. So someone build a beautiful health center in his village because he's a big person in politics, but nobody's going to access it. Poor roads, poor facilities, poor lighting. Can even have very, very good facilities. Like where I work, for example, in UCH Ibadan. The government decided, the PHCN, or what you call them, decided to bring a bill of almost 400 million for us to pay over a short period. And the government is not ready to subsidize those. I can't put a hospital like that on band A, with the meter just ticking like that. So political will must be there, the access must be there, and the fees. Let people be able to access this health. Some hospitals now, yes, talk about the minimum wage. Minimum wage minimum wage, I can tell you, may not even be able to book a woman for antenatal care in some facilities. So you need to look at all those things. The other thing I forgot to mention when I was talking was mental health. Women have to have stable mental health to be able to do a lot of things. So I think I'll stop there. I think Nonso wants to add a few things.
I had to back my teacher up. So I'll say three quick things on what I think can be done, to just make sure climate change doesn't impact service delivery, especially PHC level. So first, infrastructure. I think we just need to adapt. We need to build infrastructure now that is climate resilient. Floods will come, knock down some buildings, but there are new technologies that allow you, build buildings that can actually stand the test of time. But also there is also switching to solar, right, energy, because again, we also have our own part to play in the climate change, right? So there's an argument that, this part of the world doesn't contribute so much carbon, to the environment, but we can do our own little bit. The second is supply chains, right? Because sometimes when we have these climate disasters like floods, the challenge is now getting the drugs to the facilities. And there are solutions that have been used in other instances, even here in Nigeria. For example, I know of a program in Kaduna where because of the security challenges, drones have been used to deliver drugs. And yeah, so that's definitely possible. The third is the workforce. We need to build the capacity of our health workers to adapt, so teaching them how to use drugs like histable carbitocin, but also teaching them, how to manage conditions that are now more prevalent because of climate change, like diarrhea. So teaching people how to use ORS and so on. Yeah, thank you.
Thank you very much. Please, a round of applause for our panelists for that response. Nonso had told us earlier that Prof was his lecturer in school, so it's amazing that they are on the panel having these conversations together. So I would have liked to know further from Dr. Oyeni. Yes, he mentioned the Safe Motherhood Strategy, which is a good initiative by the government. However, we know that there are a lot of these documents, legal framework strategies, but I was curious, and I know a lot of participants would have been curious also to know what more the government is doing. We know that the conversations around climate change, especially in the health context, is new and evolving, but climate change is here to stay, so we just have to keep the conversations up around adaptability. How can we thrive and remain healthy, and our children remain healthy in the face of a changing climate? So I would just take 30 seconds each from our panelists as we wrap up our thoughts and we summarize this conversation. I would just start from Faithfulness. What are your concluding thoughts around your recommendations, especially for government stakeholders around building a more resilient health system in respect to climate change?
Thank you very much. So I would say data. Data is key. And then it's not just having bits and pieces of data, aggregating data, climate data, environmental data, weather patterns, especially in vulnerable regions. We know the northern part of Nigeria, the northeast, the northwest, are more prone to desertification, sandstorms, and heat stress because of the amount of heat and then the encroachment of Sahara Desert into their farmlands and arable or agricultural land. So it's very important we aggregate this data in these regions. For the Niger Delta regions, they are prone to warmer temperatures that serve as breeding grounds for mosquitoes, and you see them more prone to malaria. And malaria is one of the top killer diseases of pregnant women. You see the coastal regions, the same thing, the flooding. So it's important for our climate departments in different states to begin to get data monthly, weekly, monthly, yearly, and let's be able to compare, track, monitor, and compare, and then merge this data or find the correlation between weather data and maternal outcomes in those regions. By the time we find the nexus, we find the correlation, it helps the policymakers to make better policies. It helps even investors to come in and say what kind of climate resilient projects can be done in these areas for mothers, to improve maternal outcomes and neonatal outcomes. So I would say proper data gathering, accurate data gathering, and then synergizing this data between climate and maternal outcomes to have better policies, more investments that can make motherhood safe, pregnancy safe, and children safe, and more resilient to the impact and effects of climate change. Thank you.
Thank you. Chair Gozie, your closing thoughts.
Thank you. I would, repeat what the Honorable Minister said earlier today. Let us democratize the conversation around climate change. Let us take very small but very mighty steps to ensure that everybody everywhere understands climate change, knows how their activities affect climate change and what they could do to reduce the effects of climate change. Thank you.
Thank you. Dr. Nonso?
Yeah, thank you. Again, three things. Partnerships. Partnerships work. I think Smarts for Mothers has taught me that. So partnerships are really needed to address this. Policy. Our policies also need to adapt, to face our current reality, because climate change is our current reality. And I also have to agree with Faithfulness on the third thing, which I think is data. And that is really using data for action, but also using data to adapt as necessary. Thank you.
Thank you, Professor Aymaku.
Keeps going off. Thank you very much. Things have changed from before, and we must face reality. everywhere in the world, climate change is being taken very seriously. We need to take it very serious in Nigeria. And that way, together with the maternal indices that are still rising, we don't want them to go higher. So advocacy is very important. Training is very, very important. Then making good structural facilities are also necessary. Then we need to reduce the cost of maternal care in our women. Others are women will continue to go to places, they know where the good places are, but they will go to places where they won't get good health and good care. And we'll keep on losing our mothers and our babies. Thank you.
Thank you very much. So I would just wrap this panel session up with these 5 points that I'm taking away with me from the conversations that our panelists have expounded on. First, we need to invest in climate resilient infrastructure. We also need to look at what does data say and use data for action. Awareness, awareness, awareness. We need to take small steps. Everyone needs to know how their day-to-day activity is contributing to climate change and also know what they need to do to improve their environment. We need to take partnerships, collaborations, and policy very seriously. And finally, advocacy. We can't stop talking about this. We can't stop having these conversations. Yes, you can say we talk, and after talk, what's next? Where's the action? But imagine if we were not talking about it at all. So it all starts from the conversations, and these conversations should catalyze action that will improve our environment. On that note, I would say thank you very much to our esteemed panelists, and would rise for a group photograph. And I would also use this opportunity to say thank you to our participants for engaging, for your participation, for your attention, and you deserve a round of applause for yourselves too. Thank you. Please, let's rise. Thank you. Please, a round of applause as they go back. Okay, so our time for this session is up, but we are going straight from this room to have lunch. Lunch is served, and we have an hour to take lunch. So quickly find one of the 7 points, get your food, and we'll reconvene at plenary, the main hall, at exactly 3:30, so that we can have the final session for the day and call it a wrap. Thank you so much. You have been such an amazing audience. We hope you enjoy the rest of the conference. Thank you.